for that we are using a turpine. So there is a turpine in a diameter of 4, 5, 7, 9 in a diameter. So according to the socket size, first to measure the socket size with the turpine, either we need the 5 mm of the diameter or 7 mm or the 9 mm. According to that, we can make a ring chin graft. In the anterior area, expose the chin area, and then we take out the ring chin graft. So it is a very easy procedure. वो दिख रहा है व्हील चलता हुआ, that is the turpine. Okay, so full depth we go. This is according to the need, how much diameter and how much vertical height we have to augment. So this is the ring in a chin area. Okay, this is the patient. 3 mm below the attached chin area. Always remember the rule of 5-5-5. 5 mm below the apex of the tooth, 5 mm above the inferior border of mandible, and 5 mm lateral to the median symphysis area. So whenever you harvest a chin graft, 5-5-5. Center से 5 रखना है, apex of the tooth 5 and inferior border से ऊपर 5. Okay, अगर ज़्यादा inferior border पे जाओगे तो there are chances of fracture. ज़्यादा ऊपर जाओगे, superiorly जाओगे तो damage to the apex of the tooth. ज़्यादा center में जाओगे तो again there is a branches of sublingual artery and the incisive nerve branches that will make injury. Okay, so rule of 5. Same rule in a zygomatic. I think surgical बताया होगा. Rule of 5-5-5. 5 mm from the lateral margin of the बताया था कुछ नहीं? ठीक है? So this is the ring graft. So making outline of the ring graft using a turpine burr. The planned diameter. Second is the preparation of the implant site on the graft. It is important. Okay, if you remove a chin graft before placement of the implant, it is very difficult to make a osteotomy in a free graft. Correct? So हम लोग क्या करते हैं? We make a osteotomy before removing it. अगर आप देखोगे in the third diagram, preparation of the implant site on a graft. Okay, final drill छोड़ देते हैं. If you are example, if you are placing a 4.2 mm of the implant, we have to drill through the 3.62. जो लास्ट ड्रिल होती है उसके करके उसके बाद हम ग्राफ्ट को हार्वेस्ट करते हैं. ओके, देन यू प्लेस दिस ग्राफ्ट मटेरियल इनटू द सॉकेट. वंस इट इज स्टेबलाइज्ड, फिट इट इनटू द सॉकेट, stabilize it, and then you place an implant. Okay, if you see the last diagram, this is the placement of the ring and the implant. This is the implant placement. If you see, there is a good amount of bone formation and implant. Prosthetic rehabilitation. ठीक है, prosthetic rehabilitation. ग्राफ्ट के बाद sequential drilling कर चुके सब कुछ कर दिया. After the last drill, you harvest the bone graft, put it into a socket, fix it around the 4 walls, and then you place your implant. It is a ring, it's not like only the cover. It's like a full vertical depth. Okay, so fix it into the socket. वो fix हो जाएगा. It's like a बाहर का envelope थोड़ा बड़ा है, अंदर का छोटा है, उसके अंदर fix कर दिया आपने. Is the male female type. You fix it inside the socket and then you place your implant. ठीक है? उसके सेंटर में एपेक्स पे उसको बोन मिलता है बस. Whole implant is inside the graft material. Only the apex is stay on the native bone. नहीं करेगा, उसको पहले स्टेबलाइज करना पड़ता है. You have to stabilize the graft material first and then you place implant. Okay. ठीक है. This is the another case. If you see there, same like your case, there is a concavity. If you see from the maxilla, there is a big concavity. So in this case, if you see the CVCT also here, there is a no bone. So in this particular case, you have to decide either you go for the grafting or some other type of graftless procedure. In this case, only the basal implant is the only procedure, graftless procedure. Otherwise, you have to go for the grafting. Right? So in this case, particularly what I did, there is a very less amount of the bone. If you see the CBCT, we are open it up at the chin area, scoring it, and harvest the chin graft. So only whenever there is a mandible, there are two cortex. One is the buccal cortex, other one is the lingual cortex. In between that, there is a medullary cavity. So you have to remove only the one cortex with slight amount of medullary cavity. Don't try to remove both the cortex. Okay, otherwise you end up with some big complication. Okay, only with the outer cortex you harvest the chin graft. Place over the concavity, stabilize with a screw, titanium screw, and close it back. If you see here, it is completely inside the cavity, and this is the screw for the stabilization. Then after the 4 months, if you compare the pre-op and the post-op, you see there is a good amount of the bone and the fullness present on the gingival tissue. This is the width of the gingiva now, width of the ridge now. After the 4 months, if you compare the pre-op, it is around 2.2. Now after the 4 months of the graft placement, it is almost like 5 to 5.7 mm. So good amount of bone width we can achieve with the chin graft material. If you see here, this is the chin graft. If you see this radio dense area, because it is a corticated bone and maxilla is a porous bone. So you can easily compare which is the graft material. Here, this is the chin graft material. यहाँ दिख रहा है ये? अलग side. This is the chin graft, placement of the implant, and this is the process. Happy patient? But it will take time. 4 months for the waiting period, for the after the grafting, then after implant placement again 4 months. So it is almost like a 9 to 12 month process. Okay. Otherwise, if it is a delayed bone, if it is a conventional type of implant placement, you can give rehabilitation after the 4 months. So this is the ramal graft placement. Again into the concavity. This is simultaneously implant placement. So once you make a lateral side of the bone, placement of the implant. This is if you want to increase the horizontal width. So again you make a slices of the ramal graft and put it horizontally. This is for the anterior. Now we come to the graftless procedure. Only we are talking about 3, the ridge split, osteodensification already I think Dr. Raul discussed about it, and tilted implant. So ridge split to gain the horizontal width. So अभी इससे पहले हमने जितना भी डिस्कस किया था, mostly it is a vertical increase of the height or the horizontal. But ridge expansion of of the alveolar at the mid-ankylus region through the mid-cristal split. So basically what we do, we put a mid-cristal incision and open the 2 vertical plates. That is the idea behind it. But it should be in a controlled manner. ऐसा नहीं है कि आपने क्रिस्टल इंसिजन दे दिया और चीजन मारा और दोनों बोन को स्प्लिट कर दिया. So that means you have fractured the bone. Then most of the time in a ridge split technique, either we expand the bone to the some limit. For example, if it is a 3 mm of the bone, we can expand the bone around 4 mm or 4.5. That means around 1 to 1.5, not more than that. If you want it to expand till the 6 mm, most of the time one of the wall is fractured. Okay, and that is one of the cause of failure of your implant. Okay, so expand in a controlled manner. अब चल रहा है. हाँ, क्योंकि palatal bone is thick, buccal side is very thin, so it is most of the time it is fractured. उसमें उल्टा है, mandible में it is opposite. The lingual bone fracture is more as compared to the labial bone. Suitable for enhancing the ridge width must have adequate bone height. So ridge expansion procedure is only indicated when the horizontal width is 3 mm or less than 4 mm, but the vertical height is adequate. Okay, if the vertical height is not adequate, this procedure we are not able to do. ठीक है, तो इसको उसी केस में करना है जिसमें vertical height is around 11 to 12 mm, जिसमें हम implant size same ले सकते हैं and width को खाली increase कर सकते हैं. So mostly the anterior mandible and the posterior mandible is the area for the ridge expansion. Okay, so at least 1 mm of the trabecular bone should be present between the cortical plates when considering the minimum alveolar bone width for the surgical purpose. Contraindication: facial bone concavities as present and narrow ridges in the similar to the area site augmentation with the graft. So basically, if there is no medullary cavity in between, For example, there is a big concavity in the maxilla or the anterior area of the maxilla. If you see, both the cortical plates are stick together. In that particular case, ridge expansion is avoided. अगर उसमें आप करोगे तो medullary cavity नहीं होगा, तो expand ही नहीं होगा, and there are higher chances of fracture. So in that particular case, you have to go for the onlay grafting. Onlay grafting जो हमने अभी देखा था, like rammer grafting, chain grafting, any type of particulate grafting and GBR. ठीक है? अगर आपको लगता है there is very less amount of the concavity and both the cortices are not stick together, then you go for the expansion, ridge expansion. Okay? Advantage over the grafting, the ridge split may allow for the immediate implant placement. Obviously, if you expand the bone, you get a good amount of the horizontal width, you can place an implant easily. Bone then regenerate within the space between the expanded cortical plates. Most of the time, we are not need any type of graft once we expand it and simultaneously implant placement, because once you expand it, place an implant, surrounding there is a blood clot. Okay, and that blood clot has to form a new bone. Okay, but some people also try, once you expand the bone, place an implant and surrounding, because the jumping distance is more from in between the two, you are placing, most of the people are putting a graft, but there is no significant result was found according to the literature. Okay, so if you are placing an implant in an expanded bone and not putting any graft, doesn't matter. Okay, the closure should be good and placement of the implant should be good. Okay, then cost for the patient treatment is decreased because आप bone graft के साथ कुछ use ही नहीं कर रहे, membrane use नहीं कर रहे, तो automatically cost is also decreased. The traditional device initially जब हम ridge expansion करते थे तो क्या करते थे? छेनी हथौड़ा चलाते थे, chisel and mallet. So that is very troublesome for the patient. Patient के कान में sound आता रहता था, जोर-जोर से चीखता रहता था. Like कल जैसे किसी ने मेरे से पूछा था कि patient को pain हो रहा है, तो उसको pain नहीं भी हो रहा होता था, तो chisel mallet use करते pain हो जाता था. ठीक है? And the forces are, you are not able to control the forces with the help of chisel and mallet. Sometimes you are tapping more, sometimes you are tapping very slow. So chances of fracture are more in cases of chisel and mallet. So to overcome this, nowadays we have a motorized disc expander. ठीक है? तो motorized disc expander क्या है? You have to cut the crest and expand with the help of controlled force with the motorized expander. So it's like an implant body only. You can put in between the two cortices and expand slowly. Okay, so it is very controlled and there are less chances of fracture. Okay, initially जब हम use करते थे chisel and mallet, what we do, we are putting a two vertical cuts and one horizontal cut, and intentionally we do the green stick fracture to the one of the cortices. ठीक है? But अभी जो हम करते हैं nowadays, we are not giving any vertical cut around the crown planned area or the horizontal cut, but we are using a motorized ridge expansion to expand the wall in a horizontal direction. ठीक है? Now in later on, nowadays we are using a piezo device. Piezo device is also a more control. Having a more control, it expands more easily because it doesn't cause the thermal necrosis to the bone. So there are less chances of failure again. These are the initial ones, the ridge expander. These are the mallet, various expander, motorized expander, the wheel. This is for the crestal cut. This wheel is for the crestal cut. Ratchet for the screwing it, for the threading. This is the mallet we are using for separation. This is the older one. This is the RS kit by the dentium. Nowadays, nobody use it. So in the posterior area, refraction of the flap, the mucoperiosteal flap will reflect it. With the help of 7-0 burr or the Linderman burr, you can give a crestal incision. Or in otherwise, in the most of the kit we have a wheel burr. Okay, so we give a mid crestal incision. Previously, we are giving this type of two vertical cuts. That is not completely cut the buccal cortex. This is only superficial and one horizontal cut. Then deepen this crestal incision with the wheel. These wheels are coming in again in a diameter like 5, 7 and 9. According to that, we can dactyl the osteotomy side. And this is for the separation. If you see here, there is a fracture. Correct? There is a fracture on the both the side of the vertical incision. Then we are using a motorized expander and expand more. But if you see here, this is completely out from the bone. The only advantage is this: if it is completely free, if the fracture bone is completely free, you have to abandon the procedure. Okay, but if it is attached with the periosteum, then you have to place your implant and suture it back. Then it will survive. Okay. Otherwise, nowadays we are not giving a vertical cut. We are just giving a crustal incision, deepen it out, and put a motorized expander and expand the socket. So it is like a V. पहले क्या होता था, जो पहले करते थे उसमें पैडल होती थी दोनों. So it will expand from superior to inferior in a same go. But now we are not giving any vertical cut on the anterior and the posterior side. It is expand like a V. Okay, only the coronal and the middle part is expand, and there is no fracture as such. वो उसके लिए बताया था ना, इनिशियली तुम्हें बताया था कि बक्कल जो तुम्हारी इंफीरियर नर्व होती है, इट इज रन पहले क्या करती है लिंगुअली एंड देन बक्कली. Second, in ridge expansion, you always have a sufficient amount of vertical bone. That means your mandibular canal is well below and you have a sufficient height of bone. अगर आपके पास vertical height नहीं है तो ridge expansion नहीं कर सकते. ठीक है, तो कभी भी जब भी ridge expander करते हो तो आपके पास vertical height अच्छी होनी चाहिए. मतलब जो भी आप implant प्लान कर रहे हो, एग्जांपल 10, 11, 12, 13, जो आपके पास 13 mm बोन होनी चाहिए for the 13 mm of implant and 2 mm shape side होना चाहिए for the inferior ulnar nerve. So you are deeper now the side till you are 30. तो जो एक चीजल में मैलेट दिखाया था, चीजल दिखाया था, there are demarcation 6, 8, 10, 12 ऐसे. तो उतना ही डेप्थ तक आपको जाना है. ठीक है. The only thing is orientation of the chisel is always toward the buccal side, not toward the lingual side. ठीक है. लिंगुअली करोगे तो if there is a perforation, you directly end up in a floor of the mouth. ठीक है. तो वो always toward the buccal side. ऊपर ही रहेगी. जब भी आप कर सकते हो ridge expansion, otherwise not. Otherwise फिर आपको करना पड़ेगा onlay procedure, sandwich procedure या फिर lateralization of the nerve. There is another procedure, lateralization of the nerve. If you don't have a vertical height, make a lateral window on the buccal side of the mandible, remove it, and whole nerve you can lateralize it, place a implant, and उसके ऊपर nerve रख के and suture it. That is another procedure, lateralization of the nerve. ठीक है. This is the ridge split. If you see here, there is a concavity on the second quadrant, lateral side. It is almost around 3 mm. It is a case of lingual orthodontis and better Bhupender. ठीक है. So we create a space in between the tooth and the sentinel incisor and the canine. This is the CBCT. There is a 3 mm of the bone, but the vertical height is good. Okay. If you see here, there is 17 mm of the vertical height. Then IOP, after the ortho treatment, we get a good amount of the mesodistal width. This is the concavity. But in cases of maxilla, it is not hard as a mandibular bone. So you can try the ridge expansion in cases of maxilla if there is a concavity, but not in a maxilla if it is completely touching the two cortical plates. So bone continuity with the this is the first ankylosing lancet to check either I am in the center or not. Then this is the crestal rib, bone expander. This is the old one जो अभी हमने दिखाया था एक चीजल में मैलेट की तरफ. Then motorized expander to expand the bone, and after that the placement of implant. Okay, after the expansion. If you see here now, there is a good amount of the bone. If you see in this, there is an implant and there is a good amount of bone column after the expansion. That is the beauty of this procedure. If you see, this is the pre-op, and now you see the post-op, and this is the implant and the good amount of soft tissue around it. Then close the impression. ठीक है. impression ठीक लिया. ठीक है. good. क्रॉस को ने कंफर्म कर दे तो ठीक है. ये क्या है? What is this? Very good. So this is the gingival mass. Then the gingival mass here, jig trial. After jig trial, the abutment placement and crown placement. ठीक है. crown ठीक है. अच्छा ठीक है. काम अगर तुमने बहुत ज्यादा दी है, ठीक है। The goal of ridge expansion is basically to expand the ridge to allow the placement of appropriate size of implant. That is the first thing. Second, bone due to its dynamic viscoelastic nature, the thinner ridges like 3.5 can be expanded with a better instrumentation with less risk for fracture, trauma and bone perforation. So if the size width is less than 3, so try to avoid the ridge expansion. It should be 3 or 4. In between this, you can expand the bone more easily. The softer and trabecular bone quality, the lower the elastic modulus and greater the viscoelastic nature of the ridge. Therefore, the less dense the bone, the easier the bone to fill the bone expansion. Okay? Second is implant placement using osteodensification. ये तो कल हमने डिस्कस कर ही लिया था. So we can use denser bar in both the way. If we are using in a clockwise direction, it's cutting the bone. If we are using in a reverse direction, it will prevent the bone and lateralization and lateral condensation of the bone. Okay, so most of the time nowadays we are using denser burr for किसके लिए यूज कर रहे हैं? Osteodensification के लिए, ठीक है? So it is a very good tool in cases of indirect sinus lift, and mostly we are using a denser burr in maxilla, not in mandible, ठीक है? Because the maxillary bone is more porous, you can expand it more, you can dense the bone more easily as compared to the mandible bone. Second, you can use a denser burr posteriorly near to the sinus, but you cannot use denser burr in cases of mandible because there is a which structure? Mandible में कौन सा structure होता है? Inferior alveolar nerve. If you are using a denser burr in a mandible and you are going for the osteodensification, what happens? Sometimes the bone is more dense. It is denser more with the osteodensification. And apically, it will put a pressure over the inferior alveolar canal. That will again cause of pain and paresthesia. Okay, so try to avoid denser burr use in case of mandible. These burr are basically using at very minimum RPM, that is around 800. I prefer 7 to 800, and with the high torque. Torque should be 40 to 50 Newton per second is there. So whenever you use a denser burr, use with a 700 to 800 RPM and torque is around 40 to 50 for a good result. Okay, these are the two modes. One mode is, the first mode is, क्या है first mode? ये क्या कर रहा है? Densification of the bone, है ना? Reverse direction में, counter clockwise direction में, so if you see here these yellow arrows depicts there is a densification of the bone, expand the bone and densification. The second one is cutting the bone. If you are doing a clockwise direction, so it will cutting the bone and bone is coming out. In the second one, if you see, there is a lateralization, and also because it work on a pumping motion, or also called as spring effect. We are going up and down, so there is a densification of the bone, and also the irrigation system is going inside and up. Okay, so it will basically give a cooling effect to the bone. So less chances of thermal necrosis, and also it condenses the bone in an apical direction. Right? So this is the case, another case for osteodensification. If you see here, there is a edentulous area, and amount of interarch space is 12 mm, and mesodistal width is around 5 mm and the 8 mm, and quality of bone is D3. This is the pre-op CBCT, very less amount of the bone. Okay, if you see here, less amount of the bone, it is a conical in shape. So in this case, we are planning for the denser burr. So we are open up the side, we are trying to use denser burr and placement of the two implants. This is the implant placement. If you see here, there is a very minimal bone around the implant. Okay, this area is okay because we have a good amount of bone, but in this concavity near to the canine area or the premolar, first premolar area, the bone is very less. But with the help of denser burr, we can expand it. And this is the process. ठीक है, process ठीक है, स्माइलिंग ठीक है पेशेंट का. Then the telltale implant case, अभी सर डिस्कस करेंगे, डॉक्टर सुमित आएंगे, डिस्कस करेंगे रिगार्डिंग द ऑल इन 4 and all in 6. Okay, according to you, what is the best treatment modality for this case? इतना सारा पढ़ लिया, फोर्थ मॉड्यूल आ गया, खत्म होने को आ गया, क्या करोगे बताओ? दिस इज द कंडीशन ऑफ द पेशेंट. हमारे पास आते अप्रूव कराने, जल्दी जल्दी अप्रूव कर दो, बताओ अप्रूव कराओ क्या है, क्या करोगे इसमें? Implant, कौन सा, which type of implant you want to put? Basal implant, corticobasal implant, zygomatic implant, all in 4, all in 6, क्या करना चाहते हो बताओ? If you see here, we have a bone of around 3, 3.5, 3.5. है ना? क्या करोगे? Anteriorly there is no bone. If you see here, it is almost touching the nasal floor. Here also, है ना? Nasal spine. तो क्या करना चाहिए? Zygomatic is one of the option. Anything else? Zone 1 में भी bone नहीं है, Zone 2 में भी नहीं है, Zone 3 में भी नहीं है, कहीं पे भी bone नहीं है. क्या करना चाहिए? बोलो भाई बोलो. Zygomatic is one of the option. Okay, anything else? Direct sinus lift. Okay. So there is something called as modification of all in 4. सुना है किसी ने? नहीं सुना, कोई बात. और कुछ all in 4 बोल रहे हैं कुछ लोग. Anything else? नंबर ऑफ इम्प्लांट इंक्रीज कर सकते हैं. तो क्लिनिकली अगर हम देखें तो अच्छी खासी बोन लगती है हमें देखने में, तो है ना? इधर भी अच्छी लगती है, इधर भी अच्छी लगती है देखने में. एंगुलेटेड अबटमेंट, क्या बोल रहे हो? बोलो राहुल. वो तो ऑल इन 4 आ गया ना, डेड कॉन्सेप्ट आ गया. ठीक है, तो दिस इज 10 ईयर ओल्ड केस जो कभी पहले सबसे पहले किया था. दैट टाइम देयर आर नो ऑप्शन एज सच कि जाइगोमेटिक क्या होता है, ये क्या होता है, हमें भी नहीं आता था. ठीक है, तो दैट टाइम वी आर प्लानिंग टू पुट द मैक्सिमम नंबर ऑफ इम्प्लांट कि कैसे प्लेस कर सकते हैं विद अ टिल्टेड कॉन्सेप्ट. ठीक है, तो वी आर प्लेसिंग अ 6 इम्प्लांट इन दिस केस. दीज आर द इम्प्लांट्स, ऑल आर टिल्टेड, ओनली वन इज स्ट्रेट. तो उस टाइम पे क्या हुआ कि देयर इज अ न्यू कॉन्सेप्ट ऑफ मल्टी यूनिट अबटमेंट. ठीक है, तो दैट्स व्हाई वी आर सेइंग नाउ द 10 ईयर फॉलो अप है पेशेंट का. पेशेंट इज कंप्लीटली फाइन, देयर इज नो बोन ऑप्शन. द ओनली थिंग इज अगर मल्टी यूनिट अबटमेंट उस टाइम पे नहीं होता तो मैं आज कहीं और होता, है ना? तो मल्टी यूनिट ने बचा लिया था उस टाइम पे. बट इफ यू सी हियर द इम्प्लांट प्लेसमेंट इज ओके. ओके, दिस इज द एंटीरियर वॉल ऑफ द मैक्सिला, दिस साइड. दिस इज अगेन द एंटीरियर वॉल ऑफ द मैक्सिला. इन दिस एरिया देयर इज अ वेरी मिनिमम बोन. So we are putting a 6 implant in this area, premolar to premolar area. Okay, so we are engaging the anterior wall of the sinus for the last implant. Same here. This is around 17 degree. This is around 25 or 26, 28 degree, and this is 45 degree angulation. Okay, there is no bone in the center. Anterior nasal spine के आसपास there is no bone as such. So we are putting a 6th implant premolar to premolar, and then we give the process like this. Okay, if you see here, these screws are okay on the palatal side. This is also on the palatal side. So palatally, अगर screw होता है तो better होता है. If it is come on the buccal side, it is very difficult because for the aesthetic purpose also, and also the forces are not going into the axial direction of the tooth. Okay, this is the prosthesis. ठीक है, फाइन. तो ग्राफ्ट वर्सेस ग्राफ्टलेस, ईच टेक्निक हैज इट्स ओन इंडिकेशन, कॉन्ट्राइंडिकेशन. अंडरस्टूड दैट थिंग कि किस केस में हमें क्या करना है, कब हमें जीवीआर करना है, कब हमें ऑनले करना है, कब इनले करना है, एंड कब ग्राफ्टलेस करना है. ठीक है, कब बोन एक्सपेंड. द प्रॉपर केस सिलेक्शन एंड द ट्रीटमेंट प्लानिंग इज की फॉर सक्सेस. सो व्हेनेवर यू स्टार्ट विद द केस, यू हैव टू गो विद द थॉरो क्लिनिकल एग्जामिनेशन. Go thorough with the radiological examination, CBCT scan, what type of bone it is, either it is a D3, D4, D1, D2, and then after what type of treatment we are going to execute. Either you go for the ridge expansion if the vertical height is sufficient. If you don't have the vertical height sufficient or the horizontal height sufficient, then you go for the grafting procedure, or nowadays zygomatic implant or the all-in-4. ठीक है, sometimes patient is not ready for the grafting procedure, then definitely all-in-4, all-in-6 zygomatic is the best treatment option. But if you want a long-term result in these type of atrophic jaw, you always go for the grafting first. Okay, for example, in this case, if you are going for the sinus lift and putting some bone graft and placement of the implant after the 4 months, then we put more straighter implant as compared to the tilted implant. And straighter implant is always better as compared to the tilted implant, because the forces are more going into the one side of the implant. The more forces are concentrated and more chances of failure. If it is a straight implant, all the forces are going in the wrong axis of the implant and it is dispersed. So less marginal bone loss you have to see in cases of straighter implant as compared to the tilted. ठीक है, fine. Any question? इसमें दे सकते हो, एक ही तो है, ओनली वन कैंटिलीवर. एक तो अलाउड है ना, डिलीशन अलाउड है कि नहीं है? दे सकते हैं, डिपेंड्स ऑन द नंबर ऑफ इम्प्लांट. इफ इट इज 4 then it is difficult. Now it is 6. The anterior posterior spread is okay, you can give it. Reconstruction of atrophic maxilla with the bone graft is an acceptable treatment modality. And second is, in mid to moderate atrophy, other option will present less morbidity should be considered. So always go according to your plan, your treatment plan, and also think about the patient. ऐसा नहीं है कि तुम अपने लिए पेशेंट के साथ कुछ भी कर रहे हो. पेशेंट ने कहा नहीं मुझे नहीं कराना, अगर उसके पास पैसा ज्यादा है तो गो फॉर द मैक्सिमम टाइप ऑफ इम्प्लांट, जायगोमेटिक यूज करो, ये यूज करो. अगर पेशेंट को लगता है कि नहीं थोड़ा टाइम है, टाइम दे सकता है आपको, तो देन यू गो फॉर द ग्राफ्टिंग. Okay, but the GBR and your normal chin graft and the lamellar graft, anybody can do it. Anybody can do it because it is a localized graft. You can easily harvest and put it into the donor side or the recipient side. ठीक है, तो वो कर सकते हैं, उसमें कोई प्रॉब्लम नहीं है. अगर ग्राफ्टिंग में हार्वेस्टिंग करने में प्रॉब्लम है, then you start using a different type of graft material like allograft, xenograft. It is easily available now. So put a graft, put over the membrane and suture it. So your expertise basically in two things. One is the implant placement should be good according to the bone, quality of the bone, and second is the handling, soft tissue handling. How you suture it back, how you close it back, how you create a soft tissue, how you advance it. These things you should know. Okay, because sometimes if you are placing an immediate implant in a molar area, okay, molar इतना बड़ा होता है, we have to extract it and place an implant. So how you close it back? So when you giving a releasing incision, when you are not giving a releasing, when you put a graft, you should know. ठीक है, that is the only key of success for implant. More foot is closer, more successful is your implant. ठीक है, more thicker the soft tissue, more success is the implant. ये पता है ना? जितना टिश्यू थिन होगा उतना इम्प्लांट फेलियर ज्यादा होगा, मार्जिनल बोन लॉस ज्यादा होगा. तो अगर उसको थिक बनाना है तो पेरियो वाले बहुत ज्यादा करते हैं, कनेक्टिव टिश्यू ग्राफ्ट लेते हैं फॉर द पैलेट. यू कैन पुट इट, मेक इट ए बल्ब एंड सुचर इट बैक. तो ये सब स्टार्ट करो. विद टाइम स्टार्ट ऑल दिस थिंग, स्मॉल थिंग यू स्टार्ट, प्लेस अ इम्प्लांट, ग्राफ्टेड. अदरवाइज पीआरएफ मेम्ब्रेन तो सब में डालना शुरू कर दो. नीड है या नहीं है, पुट अ मेम्ब्रेन.